So. It's,
In cardiology is not that easy because
are you on nothing where you want this everywhere?
and how to manage emergency. It's
So you do stems.
exactly. So you know,
So we did my first when we got our 14 house system, we're close to 6 of
so I can see the point.
per month.
With these has the percent. You can actually that's what you're saying.
Okay.
Check that out. We all made it appointments where part of that was which is something that's linked to joint all day. It's a lost certifying what we have employee for also for the just to that area of the South Bronx. Call it exchange. It's not any they kind of been saying that. So they go down to the they see reasons in the heart. So everything is set up right.
Yeah, it does.
Okay. No, but. So he's probably here every 6 weeks and then like even be certain position. And maybe some people. But you think about it, yeah. Sure. He said yes, yes, what I did. I don't know if maybe some. Good morning, everyone. It's a great pleasure today to have on a different day of our usual cardiovascular grand round. For those of you who are connected remotely, if you have any trouble hearing, please call me or myself. It's a great pleasure today to have Kathleen Biga joining us. Kathleen is President and CEO of Cardiovascular Management of Illinois. It's one of the largest physician practice management in Chicago and in the country. She had incredible amount of experience managing to the point that she became in the ranks of the ACC to the position of president. She's the past president of the American College of Cardiology. And that was in recognition for a lot of the accomplishment that she had in really shaping the way that we practice cardiovascular medicine today. She's basically the brain behind the creation of Midaxium. And she has been able to integrate the business aspects of medicine with quality and development. So we're here to tap on her incredible amount of experience and knowledge. And in addition to that, she's a terrific human being. We had a great evening last night, shared a lot of stories. We want to welcome here to the Bronx. Pleasure to have you.
Thank you.
Okay, great.
Thank you very much. Can you hear me okay?
Yes.
Good. All right. So a little bit different grand rounds than what you're normally used to, because I know you're all excellent clinicians and clinicians to be. But one of the things that we've identified across the country is that we have phenomenal clinicians that design and create guidelines. And then we give out the guidelines. We just got our blood pressure guidelines, right? And then we expect you to take those 30 pages, better than 90 pages, I guess, and distill them and get them to our patients. So I've changed this talk quite a bit. I used to just really do a blah, blah about how to implement guidelines and implementation science. And I realized after a while that that's not really where we need to go or where we should be going. We really need to make sure that we teach our fellows specifically, and really all of us, about leadership. And as I learned a lot more about your environment and understanding where your CD care teams come from. So I actually totally redid this talk just for you guys because I think it's very different here in New York than it really is in Chicago. So my day job, I think I talk, I'm old. It's a very nice way of saying she's very old. So I've been doing this a long time. The height of my career actually was I had a 14 acute care hospital system that we had a service line. Amongst those 14 hospitals, I had 120 physicians. And then, and about, I don't know, we had about 30 advanced practice practitioners as well too. And the world changed, and it really started to change before COVID. So we conglomerated and then we divorced, and we have been divorcing ever since. So I've gone through 3 divorces in the last 2 years. Those aren't personal, those are professional divorces. We went from a 14 hospital system to a 10 hospital system. That lasted about 2 years. And then my 10 hospital system went to a 8 and a 2 hospital system. The 8 hospital system is falling apart. We can certainly talk about that as you want, because I want to make sure that those of you that decided to sit in the back know where you're going when you leave fellowship, because the world is very, very different. So we will talk about guideline directed medical therapy, but we're going to talk about how we really get there. So it's an honor to be here with you. And I'm going to start with leadership, because I am convinced that we cannot implement guideline directed medical therapy without leadership. And as I watch how our care teams are so diverse, I understand you've got a union shop here, I have a union shop. Honestly, that makes leadership even more difficult sometimes. So when we talk about leadership, what is it that we're really talking about? Well, number one, it is not a straight line. So if you had told me 15 years ago that I would have started my own company and that I would have gone away from bedside nursing, I was a critical care nurse. Nothing was better than 3 GI bleeders, a couple STEMIs, and a crashing open heart. I mean, that was my idea of a great shift. I loved the chaos that critical care units brought. But then I realized, somebody asked me if I'd go and be an administrator. I'm like, an administrator? Those dudes up on the 6th floor? No way. I said, they just sort of sit up there and make our lives miserable. But yet I did. And if you told me 3 years ago that I'd be the president of the college, I would have said you were really crazy, because that can only be a position. So you need to understand that your leadership journey, no matter who you are, you may come into clinical, but you will have a leadership journey, and it's not going to be a straight path. And what we're going to talk about, because you're awesome in clinical competencies. You could probably talk me through HEPREP better than anybody. You could do the pathophysiology of ANOCA with your eyes closed. We're here today to talk about those other things that we don't tend to teach. We're working with the program directors, because personally, I think this is really important for our fellows to understand. If I could be here with you for a week, we'd cover it all. But this morning, in 10 minutes or less, we're only going to cover the ones that I think are most important. And that is, you can't lead a team unless you understand who you are. Here's another thing. You can't lead a team unless you're committed to hiring people smarter than you are. You always have to hire people smarter than you are, because they will complement you. So we're going to talk about that emotional intelligence thing. We're also going to talk about our environment. Our environment is really strange right now. It's always been weird, but it's even a little stranger. And the amount of change that we're undergoing is the fastest I've seen in my very long time that I've been doing this. So we're going to talk about that. We're going to talk about how important it is to communicate. But first, we're going to talk about you, because as an administrator of 120 cardiologists, I used to train, Cesar could tell you if that's true or not, but I used to help educate our physicians in leadership. What I noticed after COVID is I would be putting fellows in charge. They'd come out, I'd hire them. First year, I'd go, ooh, I really need a director of my EP lab. I need a director of non-invasive imaging. I need this, I need that, because we were growing so rapidly. And the fellow, they go, okay, I call my baby docs, keep it calling my baby docs, because I'm much older. We would do that, but we wouldn't train you. We would just give you the title. And that's where we have failed. So the goal is, if we've given you the title, which is lovely, we need to give you the tools in which to do your job. Because if we just toss you into the world without giving you the tools to do your job, your mom will be very proud of you, but you're probably not going to be terribly successful. So it's really important, as we're doing clinical leadership, that we really identify for you where it is that we want you to go. I call it your true north. You've got to know what direction you're going, because if you're leading a team and you look behind you and there's nobody there, we have a problem. So you have to set that direction, and then you've got to get your team to follow you, much like implementing guideline directed medical therapy. So what is leadership? It's really all about setting direction, knowing where you want to go. If you don't know where you want to go, if you want to implement a pulmonary hypertension clinic or a cardiometabolic clinic or a cardio-onc, take your pick of all the things that we do in cardiology. If you don't know what it is that you want to do, stop and back up, make sure that you know where you're going. Because you're going to have to influence others, and that includes those people up on the 6th floor because they're running this show. And they need to make sure that what we're doing is financially sustainable. I understand you have a heavy Medicaid population. We're going to talk about access to cardiovascular care because it's critically important. We need to learn in this day and age to function on Medicare margins. That's not something hospitals are used to. Did you even know what that meant? How much do you get paid to read an EKG? We rephrase that. How many EKGs do you read a day? A few? Okay, how much you paid? Somebody take a guess.
$5.
Smart man, but it's up to $7.10. So do you know how many EKGs you'd have to read in order to pay for your medical malpractice, which is, if you're an interventionist, is about $100,000 a year. It's a whole lot of EKGs that you've got to do. So that's who can be leaders. I can teach anybody to be a leader. I used to think, no, you were born a leader, that I couldn't teach you, but that's not true. I think we can teach the tools of management, but I think we can also teach how to lead. That vision is the most important thing, because if you don't know where you're going, nobody's going to be able to follow you. So no matter where you're going, doesn't matter what your subspecialty is, you've got to know where you're going to make that progress. And in order to be successful, you can't be a top-down leader. You got to walk the talk. You can't be dictatorial. You can't say, because I said so. Doesn't work that way. Now, you probably have a few bosses, probably none here at Einstein and Montefiore, because they're all probably excellent leaders. But you do have to make sure that that's it. And here's the key. There is nobody in this hospital, I can walk from the top to the bottom. There's nobody in this hospital that's more influential than your informal leaders. What am I talking about? Need another cup of coffee. Informal leaders are those individuals that do not have a title. They're your cath lab nurse. They're your ED person that's in charge of triage. They're your secretary on the telemetry unit. They're ones that probably know more about what's going on than the CEO does. So do not forget your informal leaders. And every one of you are really an informal leader. So don't think you have to have a title in order to be a leader, because you do not. You'll probably be much more important. And then we're going to talk about the environment. Is your environment stable? Life's good. Come to work, you know exactly what's going to happen. No, and so we're going to learn two things. Number one, you've learned this one. You're going to hire people smarter than you. You walk out of the room, right? Second thing we're going to learn is the environment's not in our control. Never is it in our control. So we have to be adaptable. We have to be agile. We've got to change to the environment. Your best leaders are the ones that can walk into a chaotic cath lab during a procedure that's going south, and you look up and you go, I'm so glad Mario's here, because now I know we'll do the best we can. We may not have a good outcome, but we're going to do the best we can. It's going to be a calm situation, and we're going to follow our leader. So the very key to our environment, as chaotic as it is that you've got to be able to adapt to it. Leaders that cannot adapt to it won't be good leaders. They really won't. Now, you didn't think I was going to put Superman up there, right? So it's your superpower to have that agility and that adaptability in leadership. It is the key to a really good leader. I stole this slide. We call it swiping. Steal with integrity, pride, and enthusiasm. So feel free to swipe my slides. I have no idea where I got this from, to tell you the truth. But it's a great example of Kathy Biga. Because when Kathy Biga looks in a mirror, I see a lovely ripe banana. I can have teams that look in the mirror and think this is this old, rotten, moldy banana. If I can't see the same person that my team sees, I can't lead them. If I'm being off the cuff, if I'm being sarcastic, if I'm being short, my emails, you can ask Cesar, my emails suck. They have been bad since the day I went into leadership because I type too fast. I use dots and dashes all the time. I know that. Now I should change since I know that, but I just think it's good that I can recognize it. My emails are still sort of bad. Important in your personal life as well too, is to really know who you are, accept who you are. You can't be someone else. But you have to be able to adapt and hire team members that complement your weaknesses. So if you are a fast worker, you may need somebody who's methodical that says, hey, wait a second, we haven't thought about this, and this. It goes to that issue of designing your team. Emotional intelligence, Dan Berman wrote one of the best books on emotional intelligence. We won't go through it, but if you leave the room with nothing else today, or leave the house, your cup of coffee, whoever's listening to us online, understand that these 5 gears are some of the most important things in leadership. In true leadership courses, they will actually go through these. The one that I like the best is self-awareness. I'm an introvert, been an introvert my whole life. I can take Myers-Briggs 5 more times and I will still come out an IDTF, always. I try to fool the test. I figure I've taken it long enough. I'm going to get that E to show up someday, and I don't. I'm still an introvert. So what does that mean? Well, it just means I have to change. I have to figure out how I can be comfortable in a room full of people that I don't know. How can I do this? How do you come out of your comfort zone and do things that you want to do? And if you don't want to, that's okay. But then you probably want to take a different path. You probably want to follow more than you might want to be. Position leaders, most important thing. Don't try to be anybody else. Don't try to be Mario, just be yourself. He has his secret sauce, you'll have your secret sauce. If you try to implement, if you try to be someone else, you're not going to succeed. The other kind of key things about leaders: be truthful, be honest, package it nicely. Remember, every person you're talking to is a human being. There is somebody in the world who loves them. So you want to treat them with respect. You also want to make sure that we are inclusive. One of the things we have a hard time with in healthcare is being inclusive. It's really important that we take that filter. We all have implicit biases. We need to understand that, but we need to be inclusive. The other most important thing that I talk to physicians about all the time is please allow failure. You tend to not like to fail. I think they teach you it in kindergarten. I can usually pick kindergartners who are going to be physicians because you hate to fail. And you usually hate to fail because it's usually a patient on the other end of that might be the example of your failure. But the key to failure, if you don't allow your team to fail, they're going to be hiding, they're going to be doing things to try to mask that failure. The key to failure is not to do it again. So, and if you don't talk openly in your team after a tough code or after a tough case, how much better is it to dissect it and to talk about it than it is to sweep it under the carpet? So please allow your team to fail. And don't lead with your personal agenda. This becomes true when we talk about physician finances, when we talk about those non-clinical things. You really need to make sure that you're looking at things with a wide open agenda. It's very hard to do, but it's something that's really, really important. And of course, we've also already talked about the environment and who you are. Very important to understand who you are. So I said 10 minutes ago that I can't teach leadership. I never knew this rule existed. It's called the 70-20-10 rule. Because again, I didn't think I could teach leadership. And everybody kept saying, go for your MBA, go for your MBA. Now, I wanted to be a nurse. I like being a nurse. Being a nurse is cool. I like being at the bedside. So I got my master's in nursing. I didn't take one business course my entire career. And so when they asked me to run a hospital, I said, I can't run a hospital. I don't have any finance. They said, what are you going to do? I said, well, I guess I'm going to hire the best CFO I can find out there because I don't need to know finance. They need to know finance. So 70% of what you learn as a leader, you learn on the job. You learn by watching other people. You learn by walking into those situations, go, I want to be like them when I grow up. That's what I want to do. That's the kind of leader I want to be. It's true. Science and research has proven that 70% of what we do comes from that. 20% comes from the mentoring and sponsorship. Now, I don't have any nurses or care team people, right? If I have any remotely, hello. Our care team tends not to be as good with sponsorship as physicians do. You do a great job mentoring your young. We need to help our other healthcare team members to be nicer to their young. When my nurses complain that we don't have enough staffing in ICU, and then we give them new nurses, and then we eat them for lunch, not a good idea. So we really have to help each other learn to be sponsors, because that's 20% of being a leader, is learning to be mentors and sponsorship. So this is where you can help other team members. Should you get an MBA? Want to get an MBA, get an MBA, but only 10% of what you're gonna need as a leader, learn from your MBA. So don't think it's it's good. If you want to do it, it's good. It's not bad. It won't go to waste, but you don't have to do it. Mentors versus sponsors. Just want to spend 2 seconds because I've noticed this shift in healthcare. Mentoring always, always. You guys have been great from physicians. Last night, for instance, I found out Mario is best mentors, good fellows from Cleveland, one of my favorite doctors that I've had. He's worked with me for 25 years. You guys have the smallest world known to man. Oh, he was my fellow. Oh, it's my first year. Oh, no, he was my chief. Oh, he's my co-chief. Doesn't matter where I am. Your world is very small. You should be congratulated for that. It's great examples of mentorship. But now let's start to sponsor our units. As we climb that totem pole of success, let's reach down and pull them up. Let's give them time behind the podium. Let's let them be first author. Let's let them do the abstract. Give them those chances that you had. So not only mentoring, but sponsoring people become really, really important. I'm going to do one slide on dyad leadership. I talked about it last night. I feel so strongly about dyad leadership. You're going, what the heck is dyad leadership? It is working with your administrative team. We're not poison. We have too many of us. I will give you that. There's way too many administrators. But if you're going to run your cath lab, your EP lab, your structural lab, your AFib clinic, your device clinic, having somebody who understands the business side of healthcare is very, very powerful. It helps make your point when you get into that C-suite. They will help keep you where you can do things financially sustainable model, complement each other. I've had 4 dyads in my more than 40-year career. One of my dyads, he and I'm trying to retire. He is going to retire. And that's traumatic when you really get very close to your dyad. Doesn't matter, male, female, gender doesn't. It's all about skill set. So just a thought on what to do. So remember, right now, I've got some leaders, but you're all informal leaders. Make sure that you use that power. It's very powerful to be a leader. Collaborate and communicate. Very important. We think we can never over communicate. And if we're going to now talk about how to implement guideline directed medical therapy through leadership, communicate to your patients in a way they understand it. This is their first heart attack. They have no clue what you're talking about. You know the 4 pillars of heart failure better than anybody. They have no clue what you're saying. Ejection fraction, what the heck is that? Cabbage is something I go to the grocery store and find in the vegetable aisle. So make sure that we're communicating with our patients and with our team. And we're not doing it in silence. We talked a little bit about service lines. It's a whole big topic that we could do. So it doesn't matter what box you're in, what your square lines are. It's all about who you are and how you implement. So now we're going to transition a little bit into getting us into guideline directed medical therapy and talking about health equity. Tough topic right now in the United States. The college has decided we're not going to shy away from it because it is who we are. We believe very strongly in it. I don't know how many of you know Dr. Paul Jones from Atlanta. I was on a panel with him once and he made a comment that has stuck with me forever. Somebody said, what's health equity? Explain it to me in a sentence. And he said, health equity is when every single person across the globe can wake up every morning and believe that they have access to good quality cardiovascular care. We are so far away from that. I've got healthcare deserts in Chicago. We have 57% of our counties in the United States that do not have a cardiologist. So what is health equity and how are we going to get to it so that it's a fair and a just way of getting in to see our patients? Because without it, we know from research, we know from scientific research that the infrastructure is going to cost us more. Why? You see it here, especially maybe in our Medicaid or our self-pay patients. They don't come until they're so sick that it's going to cost us 5 times as much to get them regulated. So we've got preventative cardiology is the most underrated, under-focused part of our cardiovascular continuum. It would cost us much less if we would prevent the disease instead of treating the disease, but that's my soapbox. Okay, another slide I swiped. Love it because it sort of tells me a story. Yes, baseball, it's good. I've got everybody is trying to watch the game. Here we're treating everybody equally. They've all got a beautiful same size stool. After I gave this talk once at ACC, I went to the next ACC meeting. There was a stool behind the lectern. Why? Because we had had a speaker and she was like this. And so we thought, well, we'll treat her equally. We'll get her up on a stool. Okay, thanks very much. Why don't you get rid of the lectern? So here, we're gonna do this equitably. Yeah, just a play on words, equitably. But the big kid says to the little kid, hey, take my stool. It's great. Everybody can see the game that way. Everybody's happy. But we're still missing the point. Why not just take down the darn fence? The barrier. Why do we have the barriers in healthcare? Why do we make it so hard for our patients to get to us? Why do we make it so hard that when they walk in the ER and they're confronted by, I need your insurance card, I need this, you're clutching your chest, you having chest pain? We make it so difficult for our patients. It's no wonder that they have a hard time trusting us. So if we're really going to do equitable access, we need to do that. And we need to do it with education. I don't care if it's within your system, your organization, ACC, your subspecialty society. And I'm not going to ask this question, I asked it last night. Advocacy. Physicians are horrible at advocacy. Do you realize who makes all the rules? They're 22 years old. They don't wear socks. They know a little bit about healthcare, a little bit about banking, a little bit about retail. They're very smart people up on that hill. Between them and Baltimore, they're the ones that are determining what you're going to get paid and how you're going to do it. You have to get involved in advocacy. I'm sorry, you can't pretend it doesn't exist. The attorneys have got a phenomenal path. I hate to tell you, we suck. Science, always our infrastructure. We'll build it from science. But we can't forget the other two, or we're not going to get where we need to go. Probably one of the most important slides. You guys doing social determinants of health at all? So what we found during COVID, as smart as all of you are, only 20% of your patient outcome is going to come from your brilliance, from our guidelines, from how we're taking care of our patients. 80% of that patient's outcome is going to come from where they live, how much schooling they had, what's their economic status, do they know anything about diet, do they know anything about pharmacy? We cannot forget where our patients live and work and do. If we're telling them to have this diet restriction, this lifestyle change, and they happen to be Hispanic, for instance, and their mom cooks them salt-laden fiestas every weekend, they're going to come right back in heart failure because we haven't communicated what their social determinants are. Now, those smart people in Washington have given us money to do this. So there's certain codes and such that we can use when we're seeing patients that say we've discussed the social determinants of health. One of the things we need our CV teams to help us do is to do much better in how we determine our patients' social determinants of health. Just an example of implementation science prevention. I just can't do these talks without saying we've got to do better in prevention. We don't pay for prevention. We don't really pay for lipids. How many of our patients know their blood pressure? Our blood pressure guidelines just came out. Why is it in the office? Patient says, how's my blood pressure? It's good. Okay. Why don't we tell them what their blood pressure is? Why don't we tell them how to take their blood pressure? At Thanksgiving, why don't we have a sphygmomanometer at the dining room table and have everybody take their blood pressure? Because it's a silent killer. What's the secret? So we've got to get to prevention. I won't bore you. So Sam is my mom. I've taken Sam with me across the globe because we have an epidemic of heart failure, AFib, heart failure. The problem when my mom was diagnosed, she was an Irish lady, never sick a day in her life until she was. She was in heart failure, AFib. She has a son who's a doctor. She's got me, and then she's got a finance son. What can you do? You know, mom, you just have what you got. Anyhow, I went over to her house her first day after discharge, and she has got these pills from one side of her island to the other, and she's crying. What's the matter? I don't know. They talked to me for 20 minutes. They gave me all these pills. I have no idea what I'm supposed to do. Great, we did a great job. You know what we did a great job on? We did a great job clicking every darn box in Epic. Her chart was complete when she left that hospital, but she didn't have a clue on what to do. Luckily, she came in a way. What this represents is in my system, the 6 ways a patient can come in with heart failure. They can come into anybody. Internal medicine, the emergency room, a cardiologist who's interventional and somebody made him do clinic that day and he really couldn't care less because he can't wait to get back in the lab. No, that doesn't happen here. It probably only happens in Chicago. But we got to take care of Sam because this is what he looks like. He just walks out and goes, I have no idea what they just said. They were throwing these BNPs and this echo and this ejection fraction. Phew, I just can't breathe. That's all I know. I can't breathe. So we need to get Sam up. We need to make sure we have the exact same guideline, no matter where he comes in. We can make sure our team can talk to him because you don't have time. How many of you are in 15-minute clinic slots? You're lucky. Do you have 20-minute clinic slots? What do you think you can do in 20 minutes to somebody who has no idea what you're talking about? So we need our team to work at the top of their license. I do not want to see a physician rooming a patient. Makes me crazy. I don't want to see a nurse rooming a patient. Makes me crazier. I want my MA to room my patient. I want them to take the blood pressure and tell the patient what it is. I want the nurse to come in and ask them about their diet, ask them how they're feeling, ask them if they're doing their weights. If you do your team in that manner, your patient will think you've spent an hour with them because you'll come in and you'll wrap this whole thing up because they'll trust you, but you're going to use all the work of your team. We've got to start using our teams because we have to deliver healthcare differently. Can't help myself. So we're going to spend, if I got time, we're going to spend a couple minutes on a fee schedule. Anybody know what a fee schedule is? Everybody, what I'm talking about? You all like a paycheck? Everybody take a paycheck home? They have mortgages, like the grocery store. I heard dinners are really expensive in New York. I know parking's really expensive. You can't even drive into New York without it costing you something. Okay, so there's we have 4 fee schedules in our world. That's how you get paid. I'm not going to bore you. I don't want physicians to know how you get paid. I want you to understand the intersection between your clinical skills and your financial and quality skills. So that's what we're going to do for the next 10 minutes. Won't be too boring. So our rule, which is the fee schedule, physician fee schedule, was released in July. The final rule will come out. Anybody in here EP?
Yeah, he just looked at number
We know
4.
very well. We're fighting for a year.
Give me some, IV,
And you will continue
I
to
do it.
fight and you will not win. Do you know what you're not going to win?
We're not gonna win.
You're not going to win because our dear EP fellows, when they got the survey, so all these things are determined by a survey. If you ever get a survey, I don't care if I'm in the grave, send me an email. I'll make sure somebody's monitoring my email box because we've got to teach physicians how to fill out these surveys. What happened in this survey? My wonderful EP colleagues, whom I love to death, decided they could do ablations in 16 minutes. First time the code was valued, it was at an hour and a half. Well, what do you think they're going to do when they're looking at these results from the people who do the procedure? These weren't administrators. These were physicians that said, we're so speedy. We're so good. We can do it this fast.
On the other hand, I really believe that what you said before is more important, which is the lack of advocacy in our field.
That's right.
So SEP, HRS, we have created the
Yeah, but see,
HRA advocacy as a 6C, and we're working hard.
and are you funding it? Are the doctors all contributing or are your EP fellows contributing to it?
Not yet, but soon. But what is said to me is that in Washington, I understand the time, but medicine is not time, as you just saying. You can do in an hour or in 10 minutes. That's a skill of the operator. But the complexity of performing a transseptal access cannot be judged by a 10 or 20 minutes or 30 minutes. It has to be evaluated for how much training you need to
And
all
how much
do that
pressure
and
you
how risk you have. So it's sad that all these rules are based on timing. It's, to me, sad to observe.
Have you ever done a survey?
Yes, I've
Yeah.
done. I know very well. I actually now, because I'm on podium very often, we are trying to change that when a procedure is faster, it's not faster in time, it's more efficient. We're eliminating all the timing from every paper we publish. Every clinical trial won't report any longer the time to do a procedure. We learn. But
You learn. And in the
Great.
surveys, I will give them this credit. It's something else we need to educate to. It does talk about the mental capacity. It talks about how much time it takes. The problem is it asks you to compare it to a code. If I asked you to compare an ablation to a colonoscopy, you've probably never done a colonoscopy. Stop asking me to compare it. It makes no sense. So there's a lot of issues with it. But that people thought that was the bad news. There's more news. The other part, and again, we don't have to go through all of this, but the point I want to get across is most cardiologists thought that we had gotten a raise in the fee schedule, and we did. we did see an increase for the first time. We also saw an increase tied to what they call the MEI, which is the Medical Economic Index. We thought, that's pretty good. Except it was 2.5% buried in the rule was this efficiency adjustment. Same thing that happened with us in ablations or Watchman, I'm sorry, it's gonna happen in ablations as well too. It's not gonna do E&M. Now, why isn't it gonna touch E&M or behavioral health? Because our primary care, they're trying to shift money out of the specialist over into primary care. So they're not gonna touch E&M, but they're gonna touch all of our echo codes, they're gonna touch all of our cath codes, and they're gonna do it every 3 years. So we've just modeled out all of our codes that are going to be included, and we have about a 3% drop. Everybody will be different depending on your mix, but it's important for our administrators to understand this efficiency adjustment. But what's even more concerning to me is this part. I don't have time to get into site neutrality, although I'm gonna show you a couple slides just so you can so you can say, hey, I heard this chick from Chicago, and she was talking about, where a patient has their stuff done makes a big difference in how we get paid. That's the concept I want you to understand. This problem includes all of our procedures. See, ablation, we just got hit not very long ago. You can see our PCIs, our closures, our device checks. About a 10% hit is going to happen, and this is what it looks like. So, and what they did it in, and I'll show you the formula only to show you how complex it is, not because I want you to memorize it, is in what they call practice expense. That's what it costs to turn the lights on, staff. So you think, well, that's pretty cool. Medicare pays me, they understand I have to pay for med mal, I got to pay for my nurses. I got practice expense, but this is the part of the formula that they're going to hit. So you can see the impact on many of our procedures. I know, don't put it on, everybody's talked to HRS, they're all in the dither about this because again, it was buried. People didn't realize what was out there. So we're working on comment letters and we'll tell them how stupid this is. But the other part that makes this even more worrisome, my opinion, is I'm on tape, my opinion is opening the door for site neutrality. People keep asking me when site neutrality is going to hit. Just suffice it to say, site neutrality is the equalization of payment. Right now, there's a huge delta. To me, this is crystal clear forecasting. Just wait till next year, because this is the formula. I love showing this to docs because it usually I just do an echo. What is an echo? These are all the different numbers that give you your whopping $33 for an echo. And you can see, here's your RVU. This is your work number. This is all you guys hear about is RVUs. Here's that practice expense. What the heck is this? What's a gypsy? Gypsy is where we live. Now you really want to live in Anchorage, Alaska. Anchorage, Alaska has got the best payment. You're like Chicago. I have 4 different payment schedules because we're in 4 different districts. New York is very similar to Chicago. So this is your gypsy, where you live factor. And you can see the practice expense shows up here. So that practice expense, every time they drop it, impacts this fee schedule. They do give us credit for malpractice, very nice. But anyhow, that's the formula that gets us there. What does that translate into? So here's Medicare. This is what we get paid for an echo. But remember, patients only get 80% for Medicare. So just follow it down. So when somebody says to you, that slide I just showed you, it's only a 2% hit. It's only a 2% hit, no big deal. But you can see the difference between 24 and 25 and into 26 because it went to pressure. But what I did do was this. This is sort of when I started, left hospitals, came to physicians. I call it death by 1,000 cuts, but since we're being taped, I just call it time because they keep, it's only a couple percent, no big deal. But just take a look at what happened. $125. And then take a look, can you see down here? This is when the world really started to change. Because when we were all independent, $474 is what we got for an echo. First told us, remember I said that indirect thing was like a bellwether, be careful. The DRA Deficit Reduction Act dropped us in half, and then it was the beginning of the end. Here's all these little cuts. And by the time you're done, you're down 30%. Physicians. Technical side is sort of equal. Just real quick, I want to show you the difference. These are some of the things you do pretty routinely, right? So here's the physician fee schedule. So if I do a nuclear in my office, I get $377. If I walk across the street and I do it in the hospital, they get 1,300. Same machine, same tech, same study. What the heck? Just follow it down, EKG, 680. But yet if I do it in the hospital, now do you see why the hospitals are in trouble? Now do you see why the hospitals try to do as much imaging on their own campus as they possibly can? When we talk about site neutrality, this is what we talk about them equalizing. And trust me, they will not equalize to this number. They will equalize to this one. So that's kind of where we're heading to sort of see the changes. And you can also see it's not just us. I just put those in there for giggles, but this is really our stuff. Okay, let's talk about procedures. One of the other things in the fee schedule is they're removing the inpatient only. Anybody here do structural? Anybody do ablations? Okay, the reason we love ablations on here, shoot.
Is.
The reason hospitals love ablations right now is the payment difference between a DRG inpatient and outpatient is only $2,000. You'll see here, when you start looking at these payments, it's more like 7,000, 10,000. You can see the difference. So our ablation is going to go down again, probably next year. And when we take TAVR off the inpatient only role, we barely can make money on a TAVR now because the valve costs so much. As soon as we pay it on an outpatient basis, it's going to be a loss. It's going to be a loss.
True.
So these are the types of things, while you're learning all this clinical, it's also why I say to my physicians, I need you in the office. I know you love the lab, but in order to get a patient in the lab, I need to see 50 patients in the office. So who's going to be my general cardiologist? Who's going to be my bread and butter Who just wants to do a STEMI? Could we just please do a STEMI? Do I really have to do structural? Could you please just read an echo? Do you really need to do PET, CT, MR, structural imaging? Yes, we need to do it, but we can't forget our bread and butter. We can't forget those images that got us where we need to go. I do have ablation on. Yeah, so you can see it's only a $2,000 difference. That'll change. That's why hospitals love ablations. You want a PFA system? How many rooms do you want me to put it in? How many ablations can you bring me?
So can I interrupt you now? Or?
Yeah, absolutely.
So thank you. That's amazing. And I mean, I'm actually involved into this with the HRS at the high level, so it's very good for me. But why there is this discrepancy? It's an advocacy problem. The discrepancy is that, you know, the work review for the doctor may trending down. But the reimbursement, before we go to a sign trial, the reimbursement of the ablation for the hospital keeps going up. So I have Mario telling me, oh, you need to do more ablation to keep your target. Why? They are making more money on each procedure that I've been doing. So that, you know, is a lack of advocacy on the hospital side, or why, you know, there is this discrepancy. Because, you know, if you cut me, I expect also to cut the total reimbursement for the hospital.
So you would think I would get an increase, wouldn't you? I'm doing the ablation.
Yes.
Why is the technical fee going up and my fee keeps going down? Why is that? The hospital has a very strong lobby. Every time site neutrality comes up, their lobbyists are all over that hill. So when I go to Ledge Conference in October, I will see, will I see him? I know you're busy, but this is where this happens.
And this is why half of the state and the doctors in my colleagues are creating this ASC where they co-own.
Because they have
And
financial.
they don't care about the RVU any longer.
And HRS and ACC, yeah, we worked, you want to see efficacy? I was on the call with HRS when we were talking to
Yeah, I remember.
CMS for the ablations in an ASC. And you can see why. But as I caution everybody, don't be building 6,000 ASCs because it's going to go down.
To sanitize.
It'll go down, just like PCIs, they're gonna go down. We have to learn how to manage to that. All right, one more thing that I wanted to talk about. It's another thing in the fee schedule, heart failure. I'm gonna summarize it in like 3 words. There's like 7 slides in here, just in case you can read faster than I can talk. This is what's gonna happen next year with heart failure. It's another project that only hits the docs, doesn't hit the hospitals. It's on our fee schedule. And what it basically says is any non-invasive physician. So those of you that are intervention, you can go to sleep, EP can go to sleep. This is strictly for our heart failure and non-invasive imaging docs. What the difference is, number one, is a 2-sided risk, and they're going to start with a -9%, +9% right off the bat, right off the bat. You treat more than 20 patients with a heart failure diagnosis, they'll fall into this. We will know what physicians are going to be impacted in December. So we don't know who is. It'll probably be about half the country, I think. I only say this to make sure people are paying attention to how fast something can change and how fast it can impact your compensation. So this is the blah, blah. But the critical part of this is it going to be half based on quality, talk about quality, and half based on cost. All the MIPS things that we've sort of, do not even teach you guys fellows about MIPS anymore. It's probably just so embedded in your medical records, but this is what it's going to talk about. This is what I wanted to talk about. These are the quality metrics. In my world, 8 and 5, we're awesome. We're at 98%. Most people are. Why? Because are you on Epic Shop? So Epic is built in. You click your drugs, right? You do them. Life is good. I ran these other 3 codes because if this starts, all I can say is we're in really big trouble. My functional status test, which requires a 30-day post assessment, we're at 0. So I bring this up because when this starts, you're not going to be able to change the Titanic on a dime. You've got to start looking at these metrics because it is going to impact how it impacts your comp is going to be very interesting depending on how you're paid. But it's going to be another financial pressure that we're going to have as we go along. And you're going to be responsible for the cost. If you just read the echo, you'll be pulled in to the money. So lots of problems with it, lots of issues with it. Obviously, the college is working with the subspecialty societies. We've got lots of comments on it. But my guess is 90% of you or 99% of you have never heard about it, which is one of the things I try to do is everybody know what's coming. So I'm going to close with the care team. I'm going to go through it fast. We can have some questions because I just plead with you, no matter what your situation is that we've got to figure out how to start using our care teams more appropriately. Blah, blah, and who the care teams are. Again, you can have these slides if you want them. The important concept is what we do with them. We have to be able to empower our team. They have to be able to work within their license, work to the top of their license, but work within their license. Because we need our dietitians, we need our pharmacists, we need our social workers, we need meds to beds, we need to make sure our patients have their meds when they leave here. We need our community resource workers, we need our social workers. All those people we just have not been communicating with because we're so busy that we just can't figure out how to redefine how we're going to take care of all these patients. Patients love it when they have a care team. I have my secretaries that have been with us 20 years. The patients will call the secretary because they trust, they've seen that secretary their whole life. Secretaries, no, well, what was your weight? Okay, let me get the nurse for you. It was that trust relationship. So don't negate your contact center. They are the worst paid of our entire team, and they are the most important people, and they turn over constantly because we treat them terribly. They're the front line of your office. They need to understand. We need to spend the time training them. I digress. Our healthcare professionals tend to like it in a team-based care because they feel needed, they feel wanted, and it helps the health system because we've got to deliver this cost less expensively. We've got to get back down to our Medicare margins, as I mentioned. So, and if you say the doctor will see you now, the team will see you now. Our heart failure clinic is probably our most successful clinic. They have to see a heart failure specialist every 13 months. They would much prefer to just stay in my heart. We diurese them up there. They come to the ED. We do high dose diuretics in the ED. They know their heart failure team. And that team is not just our APPs. Our nurse does all the education. We have a foundation grant because we can't get paid for dietitians. So all those types of things become really, really important. So don't forget your team. And I usually do a talk about how to structure your team. So I just put this one up. Again, as you can see, I always like sometimes putting it into a graph, who does what, because you don't want to be duplicated. Do not ask the same patient the same question 15 times. If the MAs ask the meds, look them up. Don't ask the patient again. They'll probably tell you something different because they won't remember. So let's streamline how we deliver care. And now most of you will just say, just do my inbox. So we now have a process where our physicians don't have inbox issues. Our APP handles their inbox. All of our primary calls now done by APPs. So our physicians' call life has gotten a billion times better. We don't need to come in for stents. So those are the types of things that we talk about burnout. These are the types of things that we've got to do. And it all comes through leadership. That's why I started with leadership. And our administrators, our hospital administrators have got to realize building bricks and mortar, government is pushing us outpatient. We're eliminating inpatient only. We're building ASCs. We're building cardiac rehab in the home. We've got to make sure that we are skating to where the puck is going to be, not where it's at. We have to figure out where it is that we're going to be providing care. And with that, I just ask you to be a Jedi for me. So make sure that we are just, diverse, and inclusive. And it's been awesome talking to you. And I did leave 10 more minutes.
Well, thank you very much. It's a wonderful lecture and so needed for us. I think we love the science.
You like that?
What is the background?
Oh,
That's
it is from, where's it from? Saudi.
Oh. We love the science behind cardiology, but this is so important for us also to be able to take care of our patients. So we'll go through some questions. Please put your questions in the Q&A if you have some. We'll start with Dr. Garcia.
I mean, it's more of a question. First of all, thank you for such a really to the force. It was fantastic. I like both parts of the presentation. A lot of the things that you mentioned about leadership, and I completely agree with you that leadership is learned by looking at examples of good, but also bad leadership, which you should learn. And of course, the second part. But I'm thinking here, we're going on that we have been trained and educated in a system where we reward the high-end procedures that we do in our specialty. In fact, we survive as an enterprise here in the hospital because of that, right? Because our faculty, year after year, runs a deficit of $5 to $8 million that is really covered by the hospital because of the revenue that we generate for the hospital in procedures. But for every ablation that we lost and for every structural procedure that a CIM does is not here, there is a tremendous amount of work that has to be done by everybody else in the faculty to find those patients. And we don't rely much on primary care. Primary care volume in these hospitals, number of consults that they do per year is the same as the number of consults that cardiology does. So we run a parallel primary care service in our faculty. Without that, we wouldn't be able to generate these procedures. So I agree with you, we had to put a lot of time in the office and we have to do a lot of primary care. We have to manage a lot of patients with hypertension. We have to, in order to generate those procedures.
Right.
But those procedures are what really be able to
Keeps the
cover
hospital afloat.
the cost. So we have to really, if we're going to go ahead and cut down on the revenue for procedures, somehow we have to compensate for the other part, which I think that's the part that is missing in all this.
Yeah, a couple comments if I can, because I think you're spot on. And I hope I don't get in trouble for this. But in my opinion, this is why I believe it all is resolved in compensation methodologies. Because, and again, people disagree with me across the country, which is perfectly fine, because that's what makes us all go around. My opinion is that everybody's 60 minutes is worth as much as everybody else's. Thank you for doing 5 or 6 years. Thank you for wearing lead. Thank you for all the things you've decided to do. But you can't do those procedures if I don't feed them to you from our non-invasive cardiologists. It's just as simple as that. And the point you just made, we're seeing across the country, and I've seen it heavily in Chicago, we don't even have primary care and internal medicine because they're all going into the hospitalist role. So we are becoming that front door. Ergo, another case in point why we need APPs to help run our chest pain triage clinic that takes a lot of those front door patients in. So even though, and again, by law, physicians, when we have to do fair market valuations on everybody in order to make sure that we're meeting all the rules from Washington, I have to justify you based on your specialty. We have 4 specialties in cardiology. We have non-invasive intervention, heart failure, and EP. The rest are all just subspecializations. So you have to meet fair market value in those. But our comp model is designed in such a way that everybody's paid equal. And that doesn't go over well sometimes. And when I interview fellows, how many lab days? Question, how many lab days? I need 3 lab days. Oh, then we're not the practice for you. I said, we can't give you 3 lab days because the ratios now, I used to be for every 10 patients, I would generate a procedure. That ratio keeps going up and up and up. And now I'm at about 18. And if you want, and my big contribution margins, that's the money hospitals make them. And they have your contribution margin by doc. I don't think they don't, they do. Is ablation and surgical valves. You want to make an administrator happy, just keep giving them surgical valves and ablations. Now that's it, and it changes. It has changed. Imaging is now providing a little bit more of a contribution margin, especially CT still isn't where it belongs, but it got a little better. So I'm not sure that answered your question, but I think what we have to do, and we're trying to do this nationally. I don't think we're going to. I detest the fact that I have to do you and you and you and you. I have to do your fair market value individually in your specialty. I think we need to do it at the group level. Put me in the group level, and my poor heart failure docs are down here. My EP docs are up here. Let me equalize.
You know, I agree with the 80%, but you know, there is also the other side of the picture to be seen. I mean, because you become an EP doctor or interventional doctor because you are attracted by something. And if you are in the medical school and you look at what the difficulties that you have to go to EP versus to going to something else, if at the end you send a message that at the end there is no difference, I feel at some point less and less people will go to subspecialty. So that I agree with what you're saying, but a certain degree.
Disagree with
I mean, I cannot spend 10 more years of training for I mean, I understand the love of what I do, but you will have a crush of people going to that direction. So there has to be a kind of balance of what you're saying versus, you know, that's why I go back to, it doesn't matter, you know, what you produce or what, it matters to me how much time you need to spend in order for that things to be done properly. And that is what should determine. I mean, if you have to spend 10 more years and you need at least 1,000 of ablation to be good at it and have good outcomes, that should matter in terms of compensation. That's my personal opinion, of course. But as you said.
And as I said, you can disagree with me because here's the flip side of that. Do I have my non-invasive have to see 50 patients in order to get to one procedure? Because again, the types of patients that they're getting now, it used to be my patients would come and I image them, and now with Dr. Google, thank God for Dr. Google, because Dr. Google tells them what to do. And they often come with that full cadre of things before I ever see them. So it is a cultural belief. And it's not shared. Matter of fact, I consulted once and I got resoundingly thrown out of the room because the interventionalist and the EPs did not. Well, Cesar will tell you because that's how we structured our comp models. It's just it's a matter of opinion.
But we are going in the direction because with the cut in the RVU at the end, doing a watchman or leading to echo is the same thing. So if I have my faculty, I have to give a bonus compensation. Is going to say, well, I have to do 2 more watchmen. I read to echo myself.
Or think of structural heart or watchman or mitral. Should that non-invasive that gets $38 for doing that TEE, but is in that room for 90 minutes?
Yeah.
Should he get paid the same amount as the proceduralist? In my opinion,
yes,
absolutely, hands down.
I'm completely
in 80% of compensation models.
Don't do that.
This is $32. Thank you very much. Don't let the door hit you.
Thank you. Thank you very much for that. I wanted to ask you 2 questions. One is when we talk about the RVU's changes and this neutrality, we're leaving inflation aside. So that's the first one. How can we bring inflation into the equation? And the second is quality is very important and people should be responsible for it. But how do we avoid poor hospitals with sicker patients to get penalized like it happened in the past?
Yeah. let's do the second question first. The problem in my world, quality is 10% of total compensation. I'd say that's probably true in maybe 30% of comp models. I don't see it too terribly much in academia yet, but anyhow, that's where that's at. I think the issue with quality, however, is what is it we're measuring? Are we really impacting patient outcomes? And if you remember that ambulatory surgery model I showed you, if you think about it, yes, the beta blockers and stuff are important, but let's really think about patient outcome. That functional assessment is probably the most important quality metrics. And we didn't do it because it's too hard. It would take too much work. And that's the problem we have with quality, is that we've got to get it embedded. It doesn't matter if it's too hard or too much work. We've got to figure it out. And the first question was, inflation. Well, as I throw up my hands, the physician fee schedule is the only fee schedule in the country that does not get an automatic increase. You get automatic decreases every single year. So, no. Advocacy, contribute to your PAC. I don't care what PAC you contribute
If I can say the physician one, but the administrative one keep going up.
I
So the
should have brought that
physician go
one.
down, but the administrator fee goes up.
So I have a great, when I do my top 10 environmental factors, the growth of administrators is staggering.
Staggering.
Is staggering. I can excuse part of it because when you look at the timeline, they put all the IT support into that administrative category. Now, I don't know about you, but I still remember the first time they brought me in a computer and put it on my desk and I said, what am I supposed to do with that? I would dictate my letters on my way home from work. It was beautiful, life was great, and then they bring me this machine. Well, what has happened since they're a big black hole and they're a death spiral. If you're on IT, we love you. We do love you, but it's very complicated. That's part of the problem with administration. We have way too many administrators. Our system is way too expensive, and it's because of all these, or even quality. We have all these quality things that have become mandated, and all they've done is add cost. I was telling them at dinner last night, Karen Joyner Maddox, who you may or may not, one of my heroes in life, she's down at WashU right now. She did this most incredible lecture on the last 10 years and what we have mandated for quality and what patient outcomes look like. Do you know what impact we've had with all this mandated quality? Still have the highest maternal mortality rates. We still, ever since pre-COVID, our incidence of heart disease continues to go up. We are not getting better. We're not getting better. So we're doing something about it. That's my life.
Thank you very much. One last question from Mario.
So I was fascinated by the formula.
Did you like that?
Yeah, I like that, but I think it's missing one more factor that we should put in. Over the years, the cost of continuing medical education and credentialing has continued to rise. It's not only the cost, what it takes, but it's also the opportunity loss, right? Because we have to spend more and more and more time
Courses.
not only the courses that we have to go, I mean, the things that I have to do in the hospital for maintaining my
yeah, all that
my
online stuff.
credentialing.
Yeah.
So that has to be factored in some way in this RVU model.
Good luck with that. We tried to get the cost of PAC systems. I mean, you can't live without a PAC system. And we tried to put the cost of the registries. You can't do watch without registries. We lost because it's a zero-sum game. The problem with the physician, unlike anything else, the physician is a zero-sum game. So if they give us more money, that money you gave up, thank you very much. I'm sure. I think dermatology is applauding you. They're very happy for that money. Because I call them the food fights. They're the food fights in Chicago because when they take money away from somebody, they give it to somebody. Because at the end of the day, it's a zero-sum game.
One of the advocacy person, lobby person that we spoke told me, Luigi, don't waste your time in trying to fight this. If you want to say this, you have to look at all the specialties. Find somebody that is overpaid by far and say you should pay less this procedure in dermatology because at the end they are in a budget, so they cut and put somewhere else. So you have to eliminate. You don't fight to change yours. Find something else.
That's right.
Last one, Aldo.
I just want to get your kind of if you have a crystal ball and a kind of a little forecast into the future, because the way I see it is kind of very grim. I mean, in one side we are being pushed to do more, right? Because if your fee goes down, keep up with your salary, you need to double, triple the amount of work you do. And I feel like we're kind of kind of almost like capacity. Not to mention that it's expected for us not only to see the patients, but you have to do research. You have to not only pay for the certification, but you need to study for it and keep up with that. And that's not built into the time when you're working.
Right.
So in one time, you're kind of squeezed to the end. And your compensation is actually, going down. So people is gonna eventually not gonna do this. And I think the system is gonna break. The system is gonna say, I'm not gonna do this. So I mean, for me, and the other side is quality, right? So then they start penalizing for quality. So then if I'm seeing 40 patients, yeah, I can be efficient, but to a certain level. So once I pass my 20 patients, if quality is gonna have to go down. So I mean, they're penalizing you in quantity, they're gonna penalize you in quality. I mean, eventually it's gonna crash. So if I see my prediction is that this has to crash at some point, and then do we need kind of an entire overhaul of the entire system? Because it's not sustainable. So I just want to get your perspective in how you see this in 10 years. You predict a crash. What would be your solution if you have one in terms of an overhaul, or how you see it?
So, I have an opinion. Easy question, Devin. Very much. And EP is one of my favorite stories, and HRS, when I did this talk at HRS, I thought they were gonna lynch me.
No, we didn't.
Thought you wouldn't lynch me. The year that EP took those massive cuts, about 3 years ago.
3 years ago.
3 years ago, took these massive cuts. I watched it. And the next year at HRS, I put the slides up there. Well, I'm sure there was an EP somewhere, but EP as an entity increased their compensation by 7%. So we took this massive cut in codes and yet we increased compensation. Look at any study you'd like to look at. Cardiology comp keeps going up, keeps going up. Our rate per RVU and our employed models keeps going up. I keep thinking we're at the end. Can't. How much higher can we go? We can't. And then somehow you do more RVUs. So it used to be the average RVU was 7,600. Average RVUs now are about 9,500. My physicians are almost 11,000. Is it going to crash? It's going to crash somewhere, somehow. But the problem is, in order to fix it, it has to be blown up because it is non-sustainable. Medicare, if we did the whole Medicare talk, it's non-sustainable. It's costing too much money. So it will, how it's going to crash is the problem. Now, these types of things like that ambulatory surgery model, the care team for cabbage packaging, what's happened, those used to go away. They come, they flash, they go away. These aren't going away. So maybe it is a deciduous component. But tell me this, if the average compensation for cardiologists across the country is 800,000, how do you think 350,000 is going to set? What should the compensation for people who have worn lead, who have done training 15, 17 years of their life, what should that compensation be? That's the problem. And that's a disconnect. So I don't have the answer. But it's certainly fraught. My crystal ball is so cracked.
Thank you.
And we have to change how we deliver care. And I think for you guys, like our APNs, so we pay for all of our APNs. If you have a team model where they're all inclusive, I believe there's a way out of this that is doing the right thing from a quality perspective, because you can't, the physicians, we don't have enough of them. So I do believe care-based modeling is another way that will change how we do things. Thank you. You guys are
Thank
awesome.
you.